So hi everyone. Thank you so much for joining us for today's webinar. We're really excited to share what we've put together. Tonight's webinar is all about what's in your blood. Whenever you come to our clinic, Dr. Curnew advises you to get some blood work done. And we often notice that patients have questions. Why do I need to get my blood work done? What is the blood work for? What do certain values mean? And what does it say about my health? So in today's webinar, we want to take a look at what story your blood work is telling. So today we're going to be looking at your blood work from a cardiology perspective. Next slide, please. So before we get started, a lot of you may be joining us on YouTube. A lot of you may be joining us on WebEx. If you are interested in our videos and you enjoy them, we encourage you to sign up for our newsletters. We send out newsletters on Wednesdays and Fridays where we promote our pre-recorded videos, which we post every Wednesday, and our webinars, which happen every Friday at 7 o'clock. If you are interested, all you need to do is click the link in the description of this video right underneath it, and you'll be directed to a Google form. All we need is your email so we can add you to the list, and you'll be able to get our emails on a weekly basis. Next slide, please. And there's a lot of information we're going to be covering today, and Dr. Curnew always says that the mind is only able to retain so much. I think it's about 15 to 20% of what you listen to within a short period of time. So what we wanted to do was also put together a little summary sheet, which comprises of all the important information that we're going to be talking about today. So if you ever have questions about what does my cholesterol mean and what is a good value, we've been able to put it all together in a comprised summary sheet, which you can also find underneath the video as well. All you need to do is click the link and you'll be directed right to it. You can print it out, take pictures, whatever you need. Next slide, please. And finally, before we get into our topic today, here are some recent videos that we've done on our YouTube page. As you can see, we've talked about a range of different topics, from congestive heart failure to getting exercise to even just thanking our healthcare workers, because of course we wouldn't be anywhere where we are these days without them. So if you are interested in any of these videos, feel free to click on them either after this webinar, or if you're not interested in today's topic, you can always go to a different webinar and watch it. Those videos always stay up 24 hours, 7 days a week. So if you ever need to check out a video at any hour of the day, feel free to click on it and you'll be directed right towards it. All right, next slide, please, and let's get into the topics. So today's table of content, what are we talking about? So the first thing we're going to do is discuss why blood work is important. The next thing we're going to do is discuss how you yourself obtain a requisition form from your healthcare provider, followed by what does your blood work measure? What do the different markers in your blood work represent? And what are some good values? Next, a lot of people have questions about their cholesterol levels, and of course that's relevant to your heart health. And so we wanted to look at some of the research that discusses cholesterol-lowering medications. After that, we're going to briefly discuss how you yourself book a blood work appointment online. And finally, we're going to finish off today's webinar discussing how do you prepare for your clinic appointment at Dr. Curnew's office, and how can you get the most out of your appointment with us. All right, let's get started. Next slide, please, Jonathan. So first and foremost, why do blood work at all? It's important to understand the importance of blood work and how it relates to your heart health. So let's get right into the topic. So what is a blood test? Well, a blood test helps doctors sort of check for certain diseases and conditions. They can also help to check the function of the organs, show how well treatments or medications that you're taking are working. For example, blood tests can show you how well organs such as your heart, as well as your kidney, liver, thyroid, are working. And the interesting thing about the human body is that all of these things are connected. So when you get your blood work done, you're not just looking at how your heart's doing, but you're also looking at, for example, your kidney function or your liver function. For example, your kidneys can affect your blood pressure, your liver can affect diabetes, and these are just two examples. And these are very important for a doctor, such as a cardiologist like Dr. Curnew, to know. Blood tests also indicate a number of diseases that you may have, such as cancer, diabetes, anemia, coronary artery disease, just to name a few. Furthermore, it can also reveal risk factors for heart disease. Furthermore, blood work can also indicate if you're fighting an infection. For example, we can look to see if your white blood cells are elevated when you're fighting a virus or have the common cold or a flu. If you're feeling under the weather, for example, or we're noticing that you bruise easily, ordering a blood test which looks at how your blood work is doing, your hematology, is important so that we can sort of decipher whether your body is responding appropriately to whatever it might be fighting. And finally, it can help to manage, it can help to indicate whether the treatments that you're taking is actually working for you or whether we maybe need to change something up. And that's why it's so important for Dr. Curnew to have updated blood work whenever you come for your visit so that we can see if the medications that you've been prescribed at recent visits are working, for example, to lower your cholesterol or to help manage your high blood sugar. Next slide, please. So, here are 3 examples of how your blood tests can help you manage your heart health. You can see we discuss in this slide cardiac enzymes, we discuss urea and electrolytes, and BNP. And this is not necessarily for you to memorize all of these things and what they do, but it's for you to maybe get a bit of an appreciation for what a blood test can tell us. So in relation to cardiac health, blood tests measure something such as your cardiac enzymes. And cardiac enzymes can help diagnose or exclude whether you've had a heart attack in the recent past, depending on where these levels are at in your blood. On the other hand, urea, for example, is a protein that's found in your blood. It can help to indicate whether your kidneys are helping to release the toxins in your body so that you can maintain a healthy blood level. Electrolytes are also important for whether your heart is contracting appropriately or whether that may be contributing to arrhythmia that you may have. And furthermore, BNP is another thing that Dr. Curnew can order in your blood tests, which may indicate whether you've had heart failure in the recent past. As you can see, these are just 3 examples of how your blood tests can indicate to Dr. Curnew what might be going on, which you might not be able to see if you come in for a visit and you get a stress test or you get an ultrasound, for example. Next slide, please. So with all this in mind, how do you yourself obtain a requisition form? We'll find out about that on the next slide. So what is a requisition form? Well, a requisition form is a form that indicates what test your doctor has ordered from the lab. And the purpose of this form is to indicate to the lab what you're being tested for. When you get a requisition form for your doctor, they're going to fill it out and give it to you, and there you're responsible for printing it out and taking it to your appointment that you book so that they know exactly what they want to be measuring. Next slide, please. So here is just an example of a requisition form. These are standardized by the Government of Ontario, so they all look the same. And you can see in the top left-hand corner, this is where a doctor would put their name and their address. Oftentimes physicians may put a sticker for convenience because they fill out so many requisition forms that that's just the fastest way to do it. But you'll see different doctors do different things for different reasons. Now, whenever a doctor orders the requisition form, it's important for you to understand what you are now responsible for. Whenever you are given a requisition form, it's your responsibility to find a way to print it out and bring it to your appointment. And for convenience, it's also a good idea to fill out the information, the personal information, before your appointment, so that whenever you go to LifeLabs or Dynacare, they have all the information they need and it helps to speed up the process. For example, inputting your last name, your address, or your health card number. Next slide, please. So as you scroll down a requisition form, this right here is the different markers that a physician might be measuring. For example, they can check your HbA1c or your creatinine or uric acid. And you might be wondering, what exactly is that? Well, we're going to get into that in just a little bit more, in a lot of detail in just a few more minutes. They can also indicate, for example, if you need to get a study for your blood levels, for your hematology, for example, or if you're fighting a virus, whether you should get a test for viral hepatitis. These are just several examples, and as you can see on the bottom right-hand corner, there are other tests that a doctor can also request. For example, pro-BNP, which we'll be discussing in a bit more detail in a few minutes. Next slide, please. And finally, at the very bottom, it's important for you to check whether your doctor has signed off on your requisition form and whether it's been dated. If it has been dated, your requisition form is now eligible for use for a total of 6 months from the date at which it was provided by your physician. If it's not dated, Dr. Curnew has informed me that it is eligible indefinitely. And so it's important for you to recognize the date and know the date on the bottom of your requisition form, because you might go to your appointment and realize that your requisition form is no longer valid. And of course, that's not convenient for you. So having an idea of whether or not your requisition form is valid for use is important. And just to repeat myself, if it's not dated, it's valid indefinitely. But if it is dated, it's valid 6 months from that date. Next slide, please. So as we mentioned, your doctor is going to be providing you with this filled form. And as I mentioned, for patient safety, each lab requisition form is only valid for 6 months after the date was authorized. On the next slide, we're going to be discussing how we at the clinic are now sending requisition forms virtually. So if you're a patient at our clinic, or you've been a patient for a long time, you know that we never did virtual calls in the past. But of course, COVID-19 has changed the way that we operate. And now a lot of the patients we see are virtual over the phone. And so we needed to figure out a way to be able to get requisition forms to our patients in a safe and timely way. And that's where Medio comes in. Medio is a virtual platform which allows us to send requisition forms to patients via email. And on the next few slides, we're going to be showing you the steps for how you can download your requisition form whenever we send you an email through Medio. Next slide, please. So here, we'll take you through the steps. The first step, of course, is to click the link provided in the email. There, you'll go to a website where you're meant to create an account. There, once you open up the message, you're going to download the link as a PDF from Dr. Curnew. There, you will see the requisition form that Dr. Curnew has ordered with all of the markers that he requests. And from that point, it's your responsibility to print it out or find someone who could print it for you so that you could take it to your next appointment at Dynacare or LifeLabs. Next slide, please. So just an example of a test patient, this is what a requisition form might look like from Dr. Curnew, where you have his name on the top left-hand corner, his address, and of course his signature at the bottom. In this case, the requisition form was dated, and so it's valid 6 months from June the 29th, 2021. Next slide, please.
So one thing about that, you just backtrack one track there, is that you can see that make sure that the requisition form that you get, it's yours, it's not somebody else's. Mistakes happen. Make sure you have your proper version code. It often will have, so the way we do it, we pre-fill them based on the information we have about you. So if you moved, different phone number, you need to let people know. Also, it should have your family doctor, so you can get a copy of that. And sometimes there might be some instructions to repeat this every 3 months, for instance, every 4 months or so. So these are some of the things that you need to think about. So make sure that we're getting all the tests. And if you want something different, let's talk about it. Thanks, Stuart. Go ahead.
Thanks, Doctor. Nice to see you. I didn't notice you came in. So moving on to the next slide, this is an important one that Dr. Curnew wants everybody to know as well. As once you booked your appointment, and it's important for you to have a follow-up appointment with us at the clinic. And if you don't, it's your responsibility to call the clinic and book an appointment so that we can review the results with you. Whenever you book an appointment, whenever you get a blood work done, it's important for you to recognize that no news doesn't necessarily mean good news or bad news. Of course, every physician is busy, and so it's your responsibility to book an appointment so that we can review these with you and answer any questions you have. And that way we can have an idea of what we need to do moving forward when it comes to exercise, diet, medications, lifestyle interventions.
This is really important because I'm now giving you the ability to go for blood work. You have the requisition form, but also want you to do is that I want to be able to review that with you, and to review that properly, you need to call and book an appointment. Thanks.
Thank you. So if we move on to the next slide, Jonathan, we just wanted to promote a video that we've done in the past. This was a great short 10-minute video that our team put together, and we talk about how you can get the most out of your appointment at the clinic. So here we talk about how you can get your blood results online after you get a test done. We also discuss how we are at the clinic doing prescription renewals, because as Dr. Curnew says, you don't want to run out at an inopportune time. Like they say, you don't drive a car and run out of gas and then think about filling it up. You wouldn't do the same with your medications as well. You want to be on top of it so that you know when you need a refill. We have it sort of figured out, and we know when to expect your pharmacist to reach out to us so that we can prescribe them all at the same time so that you can have all of the medications you need. And finally, in this webinar, we also discuss medication errors. What an interesting thing about that we've noticed, and the science suggests, is that only 17% of the medications that are listed on a doctor's computer actually lines up with the medications that the patient is taking. So it's important for you to bring your medication list whenever you come to the clinic so that we can cross-reference with our records to see if they line up appropriately. So if we move on to
So,
the, go ahead.
well, actually, important is that people always complain about waiting. Well, we spend about an hour of wasted time because you ran out of pills. So it's sort of like, I don't want you to run on medications, but you need to call us before you run on medications. So if your last renewal or your last visit, I want to make sure that we give you enough pills to your next visit and hopefully for the full year. Um, and it's really important that, well, the pharmacy does that. No, the pharmacy, it's your job to do that. If you don't do it, the pharmacy is the backup. Then they send it to me. Then I have to contact you and I can't get a hold of you. Um, and it's so really is that and you're putting other people behind who have appointments. So what I'm asking everybody is to understand what pills who's responsible for, know how many prescription renewals that you have, and contact us, let's say a month or two in advance, so we can make sure that we're on the right pills at the right time. Do you still need those pills? Do you need to make some changes? So I urge you to think about doing a better job about that. And thanks so much.
Thank you, Dr. Curnew. So now we're going to transition into discussing what the different markers on your blood test represent and what we recommend at the clinic as being a good range for you to be in. So if we move on to the next slide, we're going to look at some statistics from the American Heart Association. And here we discuss the incidence of cardiovascular disease in men and women between certain age ranges. As you can see, between the age of 60 to 79, for men and women, the incidence of cardiovascular disease is close to 80%. That's 8 out of 10 people. And now if you go down on the left-hand side, you see that as you age, 80 and above, the risk increases to 90+%. What we find here is that while men are at a greater risk of coronary artery disease, they're also twice as likely to have a heart attack. Women, on the other hand, have a greater incidence of having cardiovascular disease. Now, all in all, the main takeaway here is that recognizing your risks early is imperative so that your physician can sort of act in a timely manner, and you too can be proactive in managing your health. And that's why it's important for you to have an idea of what the different markers mean in your blood work so that you can know what might be falling out of an optimal range and have an idea of what the doctor might recommend for you moving forward. On the next slide here, we're going to be showing you why this is so important. So this is a gentleman with heart failure, and you can see that when it comes to heart failure or the cardiovascular system in general, it's interconnected with so many vital organs in the body: your lungs, your liver, your kidneys, your skeletal muscles, and all in all, with poor health and poor habits, it can lead to reduced exercise capacity and subsequently reduced quality of life. And here at the clinic, of course, we advocate for preventative cardiology, and there's three-pronged system to that, of course, which is exercise, lifestyle, and of course medications and quality relationships as well. Dr. Curnew, did you want to elaborate on this slide a little bit more?
You know, people say, I've always been this way all my life. Well, if you've been that way all your life, you'll probably have some lung problems, some heart problems, some liver problems, some kidney problems, and some muscle problems, some cancer problems, and also now infection problems. So to me is that, you know, the best test for most of us is a scale. And we're talking about blood work today, but think about how you're going to change your relationship with your body size and how to make that better. Thanks.
All right, thank you. So, Jonathan, if we can move on to the next slide, we're going to now be transitioning into discussing cholesterol. And we'll click one more time, and we'll move on to the lipid panel. So the lipid panel helps to evaluate cardiovascular health by analyzing cholesterol in your blood. Of course, too much cholesterol, as many of you know, can lead to buildup and blockages in your blood vessels and arteries, and this can damage them and increase your risk of having cardiac conditions or problems such as heart disease, stroke, or a heart attack. Lipids are types of fat molecules in the blood, and cholesterol and triglycerides are two important types of lipids. If we move on to the next slide, we're going to be discussing now the different types of cholesterol, and we're also going to be discussing what the optimal ranges at the clinic we recommend for your health. So the first thing, of course, is your total cholesterol. And your total cholesterol is essentially a measure of your overall cholesterol levels. If we move down to number 2, you'll see low-density lipoproteins, often called LDL for short. And we say these are the bad cholesterols. We often associate the L at the beginning of the word with lousy, because what it does is it actually takes the cholesterol away from your liver and pulls it to other parts of the body where it doesn't need to be. And this, of course, increases your risk of cardiovascular disease. Now, according to many studies, they recommend the goal of being around 1.8 millimoles per liter, and for people with diabetes, around 2.6, and for people with coronary artery disease, less than 2.6. Now, at the clinic, Dr. Curnew recommends having it less than 1. It's a simple way to remember it. And of course, Dr. Curnew is a strong advocate, and many of us are, that lousy cholesterols don't do any good for your body, so you'd want to minimize them as much as possible. Now, moving on to high-density lipoproteins, these are the good cholesterols, H meaning happy. And that's because they actually pull cholesterol from parts of the body where they don't need to be, and they actually bring them to your liver where they want to be stored. So at the clinic, we recommend anything above 1 millimoles per liter as being a good range that you want to strive for. Furthermore, triglycerides. Triglycerides in excessive amounts, of course, are associated with cardiovascular diseases, pancreatic inflammation, just to name a few. In keeping with the theme, Dr. Curnew recommends having it less than 1 millimole per liter, so that overall you can remember your cholesterol score as being a goal of 3, 1, 1, 1. Less than 3 for total triglycerides, less than 1 for low-density lipoproteins, greater than 1 for high-density lipoproteins, and less than 1 for triglycerides.
And these are my ideal lipid parameters. You know, being an average cholesterol of 5 kills, and you just saw the numbers there, who the average 80-year-old or 70-year-old, most have heart disease. So if you want to be average and have heart disease, go right ahead. But you can do better. And this is the dream team. Now, this doesn't mean it's going to be the goal for everybody, but these are important parameters to think about. Go ahead there, Stuart. Thank you.
Yeah, and just to elaborate on what Dr. Curnew just mentioned, average cholesterol in Canada is, of course, 5 millimoles per liter, but just because it's average doesn't necessarily mean it's optimal. Even with average cholesterol, you still have about a 50% chance of developing cardiovascular disease, so it's important to always aim for the lowest LDL possible. And that's why we recommend remembering the 3-1-1-1 system whenever you look at your blood work results. Next slide, please. Now, another test associated with cholesterol is Lp(a) levels. And since about 50% of people have heart attacks have actually normal cholesterol, researchers were looking for other factors that might be influencing heart disease. And it's thought that Lp(a) may be one such factor. Lp(a) promotes deposits of low-density lipoproteins in blood vessels, and that leads to the buildup of plaque. Plaques can narrow, of course, the openings in your blood vessels, lead to hardening of the arteries, and eventually can lead to a number of health problems. And for these reasons, Lp(a) may be more of a risk factor than atherosclerosis in LDL cholesterol. Now, the tricky thing with Lp(a) is that it doesn't always respond to exercise and medications in the same way that LDL responds. The amount of Lp(a) that you have is determined primarily by the genes that you inherit and remains relatively constant throughout your lifetime. And that's why it's become a recent marker that cardiologists have looked at for analyzing whether you might be at a greater risk of cardiovascular disease.
So we're going to spend more time in the future talking about Lp(a). 20 to 30% of Canadians have this high genetic marker for atherosclerosis. So that's important. You really can't change it except by changing your parents. And if you have a higher risk, we need to think about how we're going to change that. So if you go to our webinar on genetics, we'll have some more details about that. And there's more therapies in the future right now. So it's a new marker.
Wonderful. Okay, thank you, Dr. Curnew. So if we move on to the next slide, we're going to be transitioning away from cholesterol. We've discussed all we want to talk about for now about cholesterol. We want to talk about HbA1c. What exactly is that? We'll move on to the next slide and we'll discuss. So HbA1c is related to your blood sugar. Before we get into HbA1c, let's talk about blood glucose as you know it. So blood glucose is a measure of the sugar levels in your blood. And there are two sort of ways that you can measure it on your blood work. There's glucose fasting and there's glucose random. Glucose fasting is a measure of your blood sugar after 8 hours of fasting. For example, if you woke up in the morning and you did a finger prick, then that would be glucose fasting because you were asleep for a long period of time. And this is often used when measuring things such as your blood sugar after a fasted period or your lipid profile. Furthermore, glucose random is when you measure your blood at a random moment in time. It could be right after a meal. It could be a few hours after a meal. Essentially, if it doesn't fall into the category of glucose fasting, it's considered glucose random. This is another thing that you can measure in your blood work. Now, finally, that brings us to HbA1c. HbA1c is a measure of your average blood glucose levels attached to hemoglobin, which is in your blood, over the course of 3 months. Why 3 months? Well, that's the average life expectancy of a red blood cell in the human body. So unless you're superhuman, it's going to be measuring over the course of 3 months. Now, if we move on to the next slide, we're going to be discussing what sort of ranges are good for your HbA1c levels. Now, according to studies, diabetes is considered having an HbA1c level of 6.5 or greater. And of course, this is measured over the course of 3 months. Pre-diabetes falls anywhere between the ranges of about 5.7 to around 6.4. Anything above 6 is usually something that we want to keep a close eye on and monitor. And finally, anything below 5.7 is typically considered within normal ranges. Now, ideally at the clinic, as I mentioned, an HbA1c level far less than 6, really as low as you can get, is always recommended. Now, if we move on to the next slide, we're going to be transitioning away from HbA1c, and discuss glucose fasting. So, for example, if you are a diabetic and you measure your blood sugar at home on a regular basis, it's a good idea to have an idea of what these values look like. So, for example, if you have a glucose fasting level of 5.6 or less, that is considered within normal ranges. If it falls between 5.6 to 6.9, that's considered pre-diabetic, and anywhere above 7.0 millimoles per liter is classified as diabetes. Now, glucose fasting results are often one of the best indicators to measure whether someone has diabetes, but of course, HbA1c is considered probably a better marker because it's not just measuring it at a certain moment in time, it's measuring it over the course of your past 3 months. Now, for someone who may have comorbidities such as anemia, just to name one example, it's a good idea to measure your glucose at different points in time and log it for your doctor, so you know what your blood sugar is at various points in the day, and then from there the doctor can sort of make a full assessment of what he needs to do medication-wise. Dr. Curnew, is there anything else you want to elaborate on this slide so far? I'll unmute you, sorry about that.
You said that well there, Stuart. Thank you.
Okay, thank you. So we'll move on to the next slide, and we're going to just briefly compare HbA1c to glucose random. Now, a common misconception, it happens to the best of us, is that HbA1c and glucose random are the same, when in fact they're not. We discussed just a moment ago why they're different, but you'll see that also the values line up differently. For example, an HbA1c of 6% equates to about a glucose random score of about 7.0 millimoles per liter. And one of the major reasons why these don't line up is because they're measured in different units. One's measured in percent and one's measured in millimoles per liter. However, if you're at home and you're a diabetic, for example, and you get a score of about 8.6 glucose random, you can sort of guesstimate what your HbA1c would be like over the past 3 months, simply based off of your glucose random score. So that's why if you are a diabetic and you're watching this webinar, and you kind of might find this resource helpful, it's a good idea to either take a picture or refer back to it. Take a picture, as Dr. Curnew is, and refer back to it at any moment in time in the future to sort of get an idea of what your HbA1c level might be while at home. Okay, next slide, please.
Well, that's a really important slide for people to think about this. If you can just backtrack one more slide again, is that because not too many of us really know what that really means. So if you're saying, if you just go back one more slide, go forward, I'm sorry. This slide here is really important. So to me is that, if your hemoglobin is at 7%, that means your average blood sugar is 8.6%. I'm sorry, 8.6 millimoles per liter. So totally different numbers, as you point out. So so everybody should take a picture of that and put in their brain. I don't remember all these numbers off the top of my head, but this is wonderful. Thank you.
Okay, thank you, Dr. Curnew. So now,
it's really important to understand that hemoglobin A1c is dependent on your kidney function and dependent on your hemoglobin. So if you have significant kidney problems, or if you also have hemoglobins that aren't working properly, then we have to rely more on the random and the 2 RPC blood sugar. So a combination of all the above is helpful. Thanks. And we have lots of videos on diabetes to show that too, though. Thank you.
What an interesting
So
segue,
I
because
have a question. I have a question.
Yeah.
So this glucose random is the one which we take at home, am I right?
Absolutely, that's right. So those exactly. So at home, for instance, if you're monitoring your blood sugar, traditionally we ask you to measure a blood sugar fasting from time to time, sometimes a couple hours after meals to look at that, and then randomly different times as well. So that's a fingerprint or blood sugar for most people are using different meters. Absolutely.
So basically, like I tend to take my blood sugar most frequently when I get up, and it comes around 6.8, 6.5, and I always feel guilty that why isn't it 6? So if it is below 7, I should be happy with it, am I right?
No, go back one slide there. So a normal fasting blood sugar is less than 5.6. Okay. Diabetes is definition of diabetes is a fasting blood sugar greater than 7. Do you see that? That makes sense?
Correct. Correct. I do agree on it. My only thing was that I am a diabetic patient, so I am under medication. And after taking my medication, and when I take a test at home and it comes at 6.5, 6.6, or 6.8, should I be happy or should I be looking at
Sure.
6 at home also?
So let's go back to the other values for the hemoglobin A1C. So you want the combination of all the above. So the target for type 2 diabetes, depending how old you are, what comorbidities, we're aiming for a hemoglobin A1C less than 6.5 to 7%, if you want to be very aggressive. But if you're an older individual, we let that drift up. So that's an individual target that you have to make with your doctor to look at that. So there's no right or wrong answer. It's sort of all the trends. So I rely on both the hemoglobin A1C and the sugars. For instance, you go and have a donut or just after a meal, your blood sugar might spike up, and so it's important to know that. And sometimes you can say at the end of the afternoon, or after you don't feel well, and your blood sugar is 4 or 3. So we need to put all that together to determine for you what is best. So it's like it's predicting the weather. It's not it's the overall picture that's important. It's the average rainfall that's important. It's not just that one value in isolation.
So you mean to say like I should take it sometime before meals, sometime after meals, sometime in the afternoon, but at those moment of time, should I be looking at 7? Will I should be happy with it?
No, because fasting is different before meals and after meals. So best thing to do is to write them down different times, and we'll just review that with you on your next appointment. We'll also get a diabetic engineer to talk to you about that as well. So it's a whole pattern. It tells you what you're eating. If you're eating badly, we just did a whole video on grains, and it talks about depending on if you have white flour or if you're just eating oatmeal or if you're eating couscous or if you're eating quinoa, that will change your blood sugar. So it allows you to sort of customize what's best for you.
Okay. Thank you.
Okay, thank you. And now a great segue into our next slide. Jonathan, if we can move on to the next slide, is discussing diabetes and heart disease. Now, diabetes, as mentioned, is a prime risk factor for cardiovascular disease and many vascular disorders as well. And so over time, how does this work? Well, high blood sugar can damage your blood vessels and the nerves that control your heart. Over time, it can also lead to a number of other comorbidities, such as elevated blood pressure or high cholesterol, high triglycerides, and subsequently leading to obesity. And so from a recent study that we found, the risk of vascular diseases in general is 2 times less than in people with diabetes. So the risk of vascular disease in individuals with diabetes is actually 2 times greater. And we've made a number of different videos. We've promoted it on this website right here, on our slide right here. And you can also find it underneath this video where we add the link. All in all, the main takeaway from this section is to speak with your doctor, order your blood work, write down your lab values that you have at home whenever you do a glucose fasting or glucose random test so that we can assess it at your next visit. And if a diabetes educator might be beneficial to you, then trying to order that and organize that as well is an important step that we can take as members of your healthcare team. Okay, perfect. So now we're going to move on to BNP. If we can move on to the next slide, I'll discuss exactly what BNP is in your blood work. So BNP is a protein that causes blood vessels to dilate. And this is largely released when your heart is actually in heart failure. BNP levels are often measured whenever an individual gets blood work done, mainly to rule out congestive heart failure or to determine whether an individual might actually have congestive heart failure. And as you can see, we've also listed the price on here because it's relevant for you to know that BNP testing is not covered under OHIP, and so it costs the individual $75 to get this tested in your blood work. Now, moving on to the next slide here, we're going to be discussing a little bit more about BNP. So BNP, as mentioned, is a marker for congestive heart failure, essentially measuring in your blood test how hard your heart is working. And it's dependent on a number of factors: age, weight, if you have acute or chronic heart failure. These BNP values are going to differ. BNP levels essentially go up when the heart cannot pump the way it should. A result, essentially 100 picograms per milliliter is considered abnormal. And the higher the number, the more likely an individual has heart failure and the more severe it is. And on the next slide, you'll actually see a good reference point for what optimal ranges look like. So here on the slide, you can see that for a patient with kidneys functioning optimally, anything less than 100 is considered a good number. Anything greater than 100 is kind of in the red zone. Now, for an individual that does have kidney failure, the numbers differ slightly. For someone with kidney failure, anything less than 200 is considered a decent score, and anything greater than 200, going up in the 300 range, is not considered optimal. Now, whenever Dr. Curnew orders BNP, you might actually be ordering pro-BNP, which is preferred. And it's a good idea to have a reference of those numbers as well. So for patients who are under the age of 50, a score of 125 or less is considered a good score. And anything for an individual over 50, less than 450 is also considered a good score. And as mentioned, this is always relevant on a number of different factors as well. But just know that if a doctor, your cardiologist, or anyone else is ordering BNP, it's to determine whether an individual might have congestive heart failure. And subsequently, with those results, the cardiologist can decide what's the appropriate next steps. Dr. Curnew, did you want to elaborate on that?
Yeah, so BNP stands for brain natriuretic polypeptide. First discovered in the brain, but we actually find large concentrations in your heart. And there are basically two of them we tend to measure, BNP or NT-proBNP. Basically, they change depending on your age. For instance, as we get older, they go up. In kidney failure, they go up. The more overweight, they actually goes down, surprisingly. And roughly, you can take a BNP and multiply it by 3 to get a pro-BNP, but that's not exactly true as well. So these are, unfortunately, or markers of severe risk, and in some circumstances, they could be markers for potential deaths if we're not careful about that. So they're useful. They have different ranges, and it's not all or none. It really depends if you're acutely short of breath or chronically short of breath, and how to match to that. So thank you for sharing some of that information. And it comes, like you mentioned, as a range.
Fantastic. And if we move on to the next slide here, we're going to just promote a recent video that our colleague Monica and her team made. So Monica is a great volunteer who was responsible for doing a lot of the background research on that section I just mentioned on BNP. And we've actually created a 3-part series. And in this 3-part series discussing congestive heart failure, we discuss what congestive heart failure is, what the different blood tests are, which we just discussed with the BNP and pro-BNP, the different types of heart failure, and then we conclude the series talking about treatment interventions that your doctor may recommend. So if you want to learn a little bit more about this, if it's relevant to your health or someone that you know, please feel free to check out those videos as well. They are also in the description of our videos right underneath the video that you're currently watching. And with that said, I'm now going to pass it over to Aislinn, who's going to be discussing your eGFR values.
So just one more thought about BNP. Just backtrack one slide there. So this is, if you remember that picture, that overweight gentleman, and that basically you're overweight. Am I short of breath, lack of energy because I'm overweight, because of congestive heart failure. And if your BNP or pro-BNP is elevated, that points more towards the heart. You can have lung problems, you can have deconditioning, you can have anemia, some renal insufficiency. So it is complicated why you can be short of breaths. And so BNP and pro-BNP is really, it tells you a lot about your prognosis, how much time you have left, and how we may have to change your therapies. It helps with the diagnosis, and it is one marker that I find very, very useful. Thanks. Go ahead there, Aislinn. Thanks.
Perfect. So we're going to talk a little bit about the estimated glomerular filtration rate, or your eGFR value. So this gives us basically an idea of how well your kidneys are functioning, and it's usually used to diagnose and monitor chronic kidney disease. So to get an idea kind of how this test tells us about kidney function, we have to talk a little bit about how the kidney actually works. So in the diagram on the top right, you can see the diagram of a nephron, which controls the levels of different byproducts that get passed in your urine. So the glomerulus is labeled on there. It's kind of a bulb-like structure right at the beginning of the nephron, so right at the top. And it almost acts like a coffee filter. It kind of stops the larger formed elements in your blood, like your red blood cells, your platelets, and other proteins, from entering your urine. So the rate of filtration of the glomerulus will determine how well your kidney can clear waste products from your blood. So your eGFR is calculated based on one of two standard formulas that take into account things like your race, your sex, your age, your height, and your weight. So this is something that the lab will do for you when you go to get your blood work done. So for the lab to be able to calculate your eGFR, they have to measure your serum creatinine levels. So creatinine is a byproduct of a compound called creatine that your body uses to basically supply energy to your muscles and other parts of your body. So the body will produce and release creatinine into the bloodstream at a fairly steady rate. And then it's processed and removed from the bloodstream by your kidneys. So higher levels of serum creatinine usually point to kidney dysfunction, but they can also be influenced by things like really intense physical activity and high dietary protein consumption. So if you're on a keto diet, that can potentially influence your eGFR value. So an eGFR of 90 or higher is considered normal kidney function. That means your kidneys are doing well, they're working, they're doing their job. Levels in between 16 and 89 show various stages of kidney dysfunction. So mild decreases in kidney function will put you at 60 to 89, moderate decreases will be 30 to 59, and then 16 to 29 shows severe kidney dysfunction. Once you get into 15 or below, that's when you're getting into kidney failure territory. And that's usually where dialysis and kidney transplants are considered. So a diagnosis of chronic kidney disease usually requires your eGFR to be 60 or below for around 3 months. But once you get into 15, that's when you're getting into kind of danger territory. So your eGFR level will decrease with age as the kidney becomes more ineffective at removing waste products, but conditions like diabetes can decrease your eGFR much earlier in life. So an important thing to note with these calculations is that they're usually invalid for people over the age of 70 because of large decreases in muscle mass. It still gives us kind of a general idea, but it's not something to live and die by once you're over the age of 70. And there's also a different equation that should be used for people below the age of 18 because they're not done growing, they're not done developing yet. Another important thing to note is that eGFR is just an estimation of your actual glomerular filtration rate. So to measure your actual GFR, it requires a couple of different tests, one of which is an inulin clearance test, and it's not usually ordered in labs. It's mostly used for research purposes.
So if I got this right, Aislinn, so what I would think is that a GFR of, just think about 100%, between 0 and 100. So if your kidneys are working 100%, that's 100. If your kidneys are working at 15%, that's 15. So it's not totally true, but it's a good way of looking at this. And once, mentioned kind of interesting is once your kidney function is down to 15, means you probably require dialysis. Now, you're mostly asymptomatic along the way. So when your GFR is 80, you don't feel it. When it's 60, you don't feel it most of the time. And so this is how doctors and before at least. Thank you for sharing that.
All right, so now we're going to transition from the kidneys onto the liver. Okay, awesome. So the really important enzyme that we're going to talk about is called alanine aminotransferase, or ALT. And this is very common, commonly searched for to determine how well your liver is working. So ALT is a specific enzyme that's found predominantly in the cells of the liver. So they're not usually found in the bloodstream, but when you have higher and elevated levels of ALT from your blood work, it suggests that there's more damage to the liver, which is why this enzyme is getting out into the bloodstream. So there are a variety of different ways that this could happen through heavy alcohol consumption, hepatitis, which we're going to talk about a little bit later, obesity, heart failure, and even some medications like acetaminophen that are also processed in the liver, which is why when you consume alcohol, you don't take acetaminophen because that can really severely damage your heart. And all of these can lead to elevated ALT levels. This is just one of the ways that we look at the liver function and evaluate it. There are other tests as well, including looking at your bilirubin, albumin, alkaline phosphatase, and aspartate transaminase. And these are just different ways of estimating how damaged the liver is. For ALT specifically, we're going to be looking for that good range of 17 to 63 international units. There are different units, some used by different labs and different providers across Canada and the US. But the IU is the international standardized unit, so 17 to 63 is kind of what we're looking for. And if you get something different, your doctor will be able to use those units instead, or you can search it up and see how they can transfer over. This ALT is really important, as I mentioned, for liver function, and this is especially important for patients who might be dealing with heart failure or valvular disease that can cause a backlog in the right atrium and prevent it from filling properly. This can cause the blood supply in the towards the liver to kind of swell up and cause this damage to the liver that would result in this increased ALT. So different ways you can help manage this are by losing weight or maintaining a healthy weight. And the best thing obviously is to cut back and actually stop drinking alcohol, because that is very hard on your liver, and especially if you have atrial fibrillation as well, then alcohol can also exacerbate symptoms of that. So I know it's summer, but if you can try to cut down on your alcohol, then that would be really really helpful to your health. I'll let Dr. Curnew comment if he has anything to say on the liver.
Yeah, thanks for sharing that. So there are different liver function tests. The one I use the most is ALT. And at some point in time, we explore liver tests in more detail. That's wonderful. So we can use that. And unfortunately, the leading cause of cirrhosis in North America at this point in time has been called fatty liver. And fatty liver most likely is related to just being overweight. So another emphasis to try to get that weight down as well. Nothing easy about losing weight, but you feel so much better. And so do your insides. Go ahead.
Okay, I think I'm passing it on to Jonathan now. I think he's going to talk a little bit about electrolytes.
Yeah, so I'm actually going to cover a few more general biomarkers that relate to a bunch of organs around your body and sort of see how we can tie those into the heart. And first, I'm going to go a bit into electrolytes. So when you hear the word electrolyte and get maybe an electrolyte panel ordered during a blood test, they're usually measuring most commonly sodium, which is the little Na, and potassium, the K over here. But electrolytes can also include other metals that might be in your blood, because these are really important sort of like allowing your organs to function. I would kind of say that two key players in maintaining electrolytes in your body are probably the heart and the kidneys. Uh, they with electrolytes, the thing is that they sort of tie into water and blood pressure, and like imbalances in electrolytes are kind of like pointers that your blood pressure is going to be thrown off. And they can also kind of point at issues with like general nutrition and digestive issues and even kidney disease if your body's not able to properly regulate electrolyte levels. So it's a good idea to measure these electrolyte levels even to assess like general health. But then even in patients with kidney disease and other diseases, it's a good idea to keep checking and like to keep watch on electrolyte levels to make sure that they don't fluctuate too much and sort of like throw off health. And I've sort of like indicated like a healthy range here for sodium. It generally tends to be about 135 to 145 millimoles per liter, and potassium about 3.5 to 5. And like I said, frequent electrolyte testing over time is important when you have things like kidney disease to make sure that the kidneys remain stable and that there's no sudden decreases or declines in kidney function. And like Aislinn went over, the nephron and the glomerulus are like the main filtration components of the kidneys. And what they actually do is that they regulate levels of sodium and potassium and other electrolytes in your blood just to make sure that your blood pressure is like stable. So yeah, Dr. Curnew, do you have anything to add about this?
No, I think you handled it well. So these electrolytes can change, and all your blood work can change if you're dehydrated or not. So one of the systems in your body is your kidneys get rid of acid, so we can measure things like bicarbonate, and they get rid of potassium. So these are things that we can take a look at that. Some medications can influence that. So I'm very keen on knowing people's potassium levels at times and other electrolytes as well. Thank you for sharing that.
Yeah. And something also that Aislinn went a little bit into is creatine kinase or creatinine, as she explained. So creatinine is typically like stored in your muscle cells, and which also includes like the heart muscle and kind of a bit in other organs like the kidneys. So I've kept a range here for sort of like measuring creatinine levels like during a blood test. Usually oh, their sounds are wrong. Usually less than 55 or like 30 in males and females units per liter is a healthy, safe range. And like greater than above 135, like around 135 and 150 tends to like point at something like some sort of damage to your muscles. Because when muscles are damaged, they start to release the CK, the CK enzyme into the bloodstream when it's not supposed to be there. And that can also be an indicator that maybe there's some like general damage around your body, and that's why the CK is elevated. But I'm pretty sure one thing when it comes to the heart, usually like great elevations, like when they're like suddenly in the thousands, these creatinine levels is when there's like some significant danger to your actual heart muscle and there's like a lot of damage. When it skyrockets to a level like that, there might be something like you may have been exposed to toxins that may have caused a lot of muscle damage, or you might be having it. Creatinine is also often sometimes used as a measure of like a second heart attack, and a symptom that like might cause someone to test for creatinine is if you have a lot of muscle pain or weakness, obviously, because they'd want to check, the doctor would want to check if that pain or weakness is related to like mass muscle damage. Dark urine is also a good marker because then it kind of also points that there's high levels of creatinine in the actual urine. A common follow-up test to like if like there were to be this high level of creatinine would be checking what type of creatinine is actually in the blood and like what type of creatinine is actually like elevated. Just because like here like CKBB, CKMM, CKMB on the lower right there, they signify the different types of creatinine that come from different areas of the body.
So one thing to remember is CK is your muscle mass, and if you have no muscles, your CK will be lower. And if you're more muscular, CK will be higher. And people of dark skin have higher CKs compared to white Caucasians. And normal CKs, and depending on the units you're using, are usually a little bit higher than that. You know, usually about 200 to 300 range. And just going outside and running around, get kicked in the shin, your CK goes up. So I don't usually get too concerned about your CKs until usually they're over 1,000 to 2,000 range for many people. Your urine can be dark for all sorts of reasons. One is that you're dehydrated. So if you lose the ability to pass urine, that's something that we need to talk about. So CK is just a muscle enzyme. We don't tend to use CK in B fractions anymore. We use something called troponin values right now for looking for specific, because CK comes from all sorts of muscle, and the ones that come for the hearts are called CKMB, or now troponin values are something that we use a little bit more. Yeah, lots to learn. Thank you for sharing that.
Yeah. And I guess also like thanks for mentioning like the difference with races. That's a cool fact to know. So yeah, I'm going to talk about two vitamins also that are often measured in the blood, like because your doctor might want to check these two levels just to make sure that your heart is functioning properly. One being vitamin D and the next being vitamin B12. So yeah, vitamin D is an important vitamin within your body because it helps like maintain calcium levels and phosphate levels within your actual bones. So you need vitamin D to be for your bones to be like keep their strength and maintain their integrity, and for the calcium and the phosphate that's in your bones to stay in your bones. When your vitamin phosphate levels might also be thrown off by that, and sort of tying into that, because calcium has like some important functions when it ties into the heart. Vitamin D levels also point at heart function. So when you have deficiencies in vitamin D levels, you probably have bone issues, and like that's often seen with rickets and osteoporosis. But also deficiencies in vitamin D kind of like indicate increased risk for like MIs and other forms of heart disease. So it's good to keep a check on these on these levels, and I guess like nutritionally maintain vitamin D levels so that no long-term effects tend to end up impacting your heart and bones. And so go ahead.
If you go back to vitamin D, we're in a frenzy right now. Everybody's been measuring vitamin D levels, and true in North America, we have less sun exposure during the winter time. So if I was going to get my vitamin D level done, I would measure it just before at the end of the winter time, because that's going to be your lowest value. I get my vitamin D level by going outside for 15 minutes plus every day. And that's a great way of looking at it. The best way to make my bones stronger is exercise. And with vitamin D comes calcium. Now there's a association, and there's some data that too much vitamin D and too much calcium can actually cause more heart attacks. So, and the range for vitamin D is quite wide, and so is that. So to me, the whole world's taking vitamin D right now, and you can see some of these levels will come back. That's good that you're showing some of these levels, and it's a big range, and so what is the optimal vitamin D level? We got more to learn in this area right here, but as a general concept is that vitamin D levels are not basically paid for by the government except for certain indications. For instance, if you have established osteoporosis and others, and we can talk about that as well. Thanks very much. Anything else you want to say about vitamin D? So my vitamin D, I don't take vitamin B pills. I take vitamin D from exercise, and I get my bones stronger by exercise as well. So vitamin D I get from the sun, and my bones are stronger from exercise. Thank you.
Yeah. Before I go over B12, I might mention the levels, like you said. So I think doing a lot of reading, there was kind of like a debate, like you said, like a well-established safe level, but I guess it's good to keep it at a healthy like balance. But there tends to be debates like what the appropriate lower limit is. I guess some people say an optimum would be 20. Like a good lower level and would be 20, and some doctors also say 12.5. Though I guess to be safe, it's always a good idea to keep it above 20 when stuff like this isn't too established. And yeah, just talking about B12, the other one I had there, we all know probably vitamin B12 is a B vitamin, one of the most commonly measured B vitamins. It's important for two main things: your nerve health, because your nerves need it to sort of like function properly, and then also it's important for your general blood cell health. So lower B12 levels can often be tied into like anemias, and they might be ordered for when you have symptoms of anemias, and your doctor might want to check your B12 levels because of that. And yeah, here I've indicated like a range, so like similar to vitamin D. When you start to hit like a lower 200 picograms per milliliter, around then is when you should be concerned. And vitamin B12 these days tends to be supplemented in a lot of different foods. And these are like even vitamin D, just because like the market is concerned about like maintaining your general heart health and your general like bone health, nerve health, blood health. But it's always a good idea to keep a watch on these, especially when you're at risk for developing anemias and when you have other nutritional deficiencies.
So it's interesting is that if you're a vegan, because vitamin B12 comes from basically plant source, I'm sorry, from animal source products, from the microbes that animals eat. And so if you eat dairy, you get vitamin B12 in that area. So if you're a vegan and you're worried about your vitamin B12 levels, that's not unreasonable to get from time to time. So thanks for sharing that.
Yeah. Personally, that is something I did try veganism when I was a teenager, and my B12 levels did fall quite a bit. So yeah, that was a good point. And one of the last few ones I'm going to mention is prostate-specific antigen. This is a little bit different from the other few ones that I've talked about. Prostate-specific antigen is actually a protein that is released by the prostate gland, so obviously only in men. And similar to creatinine, it's typically released at a stable level. But in prostate cancer, sort of like there's an over release of this prostate-specific antigen into the blood, and that kind of elevation that might be seen in a typical like say your doctor suspects that you may have prostate cancer when you have a physical, and they do a blood test to check for levels of prostate-specific antigen. When this protein tends to go up in the blood, it might point that there might be something going on that's wrong with your prostate, and like a healthy level tends to be between 1 to 1.5, but then above 4 is sometimes a cause for concern, because like that high level of protein within the blood might point at potentially cancer in the prostate gland.
Now, this is another controversial area. You can notice that you can only interpret these into proper context. So we know that there's two forms of prostate cancer. There's an aggressive form and there's a slow-growing form. In fact, if you take an 80-year-old male, 80% of the prostates will have cancer cells in them. And so it's a slow-growing process that probably won't affect your lifespan. And sometimes is that we worry people by measuring these prostate-specific antigens, because they can go up by things like infection at times as well. And you know, the how to manage that can be a challenge, but certainly we can create a lot of worry for some people, and for some people we detect cancer early as well. So that's an individual decision whether or not you should have that done or not. So thanks for sharing that.
Yeah. And I think I'm going to hand it off now to Aislinn or Matthew to talk about iron.
Perfect. So iron is really important for our body. Basically, it's a vital part of a protein called hemoglobin, and hemoglobin is what carries oxygen throughout our body and basically supplies our entire body with the oxygen that it needs. Next slide, please. So ferritin is a blood protein that contains iron. A ferritin test will help your doctor understand how much iron your body stores. So if a ferritin test reveals that your blood ferritin level is lower than normal, it indicates that your body's iron stores are low and you likely have iron deficiency or anemia. If a ferritin test shows higher than normal levels, it could indicate that you have a condition that causes your body to store too much iron. It could also point to things like liver disease, rheumatoid arthritis, other inflammatory conditions, or hyperthyroidism. Some types of cancer will also cause your blood ferritin level to be high. So ferritin levels do affect your cardiovascular health. Low levels can lead to heart failure where your heart isn't pumping as well as it should be. And low levels will also have symptoms including increased heart rate and difficulty breathing. High ferritin levels can also cause problems, so you've got to kind of find the sweet spot right in the middle. So high ferritin levels can cause pain in your joints, abdominal pain, and more. And like I said, that can be a result of many different circumstances such as alcohol abuse, infection, liver disease, genetic conditions like hemochromatosis, rheumatoid arthritis, and overactive thyroid, or some types of cancer like leukemia. Next slide, please. So normally iron is transported through the body by transferrin, which is produced by the liver. In healthy people, like I said, most iron is incorporated into hemoglobin in our red blood cells. The remainder is then stored in the tissues as ferritin, the protein that we just spoke about. So the results of transferrin tests, TIBC or UIBC, are usually evaluated in conjunction with other iron tests. So a summary of the changes in iron tests seen in various diseases of iron status is shown on the table in the slide here. So a high TIBC, UIBC, or transferrin usually indicates iron deficiency, but they are also increased during pregnancy and with the use of oral contraceptives. A low TIBC, UIBC, or transferrin may also occur if someone has malnutrition, inflammation, liver disease, or nephrotic syndrome. But again, usually these tests are not used to assess these conditions alone. They're kind of used in conjunction with other iron tests and other blood tests to evaluate the overall functioning of your body. Next slide, please. So eating foods rich in iron can really help to prevent and treat iron deficiency. So things like red meats, legumes, seeds, nuts, green leafy vegetables, iron-fortified grains, and dried fruits are great for this. And you can always check the nutrition facts label to see how much iron you're getting in your diet, and if you potentially need to take more or less. Next slide, please. You can also enhance your body's absorption of iron by drinking citrus juice or eating other foods that are rich in vitamin C at the same time that you eat high iron foods. So vitamin C is in things like orange juice, broccoli, grapefruit, kiwi, leafy greens, melons, and oranges, and it will help your body to better absorb the dietary iron that you're taking in. So even though you might be consuming a lot of iron-rich foods, if you're not able to absorb that dietary iron really well, then you could still deal with anemia and low iron. So having that vitamin C alongside it is important for proper absorption. Next slide, please. Oh, there's all the vegetables, very helpful for vitamin C. So we talked about a lot of different treatment options in the last webinar, but we wanted to kind of throw in this interesting tidbit about iron therapy. So iron therapy can be used to help treat heart failure and has three main goals that it achieves. It helps to improve patients' symptoms and quality of life, making them feel better. It reduces hospital admissions, and it increases survival. So patients will experience reduced mortality and less premature death. Next slide, please.
So actually, if you just back, oh, here you go. That's good. Keep going. Keep going. You got the study.
Perfect. Next slide. Perfect. So this is the AFFIRM HF trial, and it's a trial in 2020 that looked at iron therapy for heart failure. So an iron carboxymaltose treatment was assigned to half of the patients, which was around 550, and then the other half received a placebo treatment, so something that didn't do anything, basically just like a sugar pill. So there was no difference in cardiovascular death between the two groups, but 217 total heart failure hospitalizations occurred in the treatment group, the ferric carboxymaltose group, and 294 occurred in the placebo group. So that gave a hazard ratio of about 0.79, favoring the iron carboxymaltose treatment, and it was concluded that fewer days were lost due to heart failure hospitalizations and cardiovascular death for patients assigned to this treatment group compared to the placebo. Next slide, please.
Actually, if you stay on that slide, if you actually look at this trial, it's a relatively modest-sized trial, 1,000 patients. These are in people that have congestive heart failure that's been well established. It doesn't really change mortality at this stage. So your slide suggests a possible change in mortality. I think we're still learning about that, and this is a new emerging therapy. And this is actually by infusion of iron. So you have to get through intravenous iron therapy. And that's why I think of, ferritin values, less than 200 or so. Different definitions of iron deficiency is quite broad. And something called transferrin saturation. So it has to be less than 20% or so as well. So this is something that's becoming more and more important. And to me is that I don't want to hook up everybody who has congestive heart failure, get infusions of iron. So I'm glad you put the slide about the diet there, is that, as you know, women lose iron through their periods. And it's less common for males to be iron deficient. So if you're iron deficient, you have to think about, have we missed something? Is there underlying cancer of your bowel, for instance? Or is your bowel just fried or frail, that you have an ulcer in there? Or we have something called diverticular disease. So it opens up a whole platform of investigation. So this is actually new emerging data about iron therapy. And so I'm going to try to get my iron from leafy greens and vegetables and nuts. And maybe I'm going to have an orange and some watermelon at the same time when I'm having my salad. At the same time, put a few slices of orange in there, some other nuts and things of that nature, to try to increase my absorption of iron there. Thanks. Go ahead there, Aislinn.
Perfect. So if we go to the next slide, we can finish off with the AFFIRM trial. So other trials have been performed on replenishing iron levels in heart failure patients, but this AFFIRM trial published in 2020 represents the latest in our understanding of iron replacement as heart failure therapy. Like Dr. Curnew said, a lot of this is still emerging knowledge, and we have to kind of look into this more. Not everything is known. But basically, they found that iron replacement therapy did have a positive effect on patients with heart failure. So it's potentially an option.
So it's very interesting. This is being studied more. So you can see there's different definitions of ferritin, and these actually used more liberal diagnoses here. And so a ferritin less than 100 or basically a ferritin under 300 with transferrin saturation less than 20%. So if you want to take a picture of that, that's a good slide to put in your repertoire of numbers there. And this is emerging data. This is pretty exciting because you don't have to be anemic to feel lousy. Iron is involved in multiple different enzyme activations, different parts of the body, and just having a low iron store can be problematic. Now, having too much iron can also be problematic too as well. It can actually damage, lead to cirrhosis. You mentioned things like hemochromatosis, and we know that alcohol causes your body to keep extra iron on board, doesn't get rid of it as well. And just simple infections can cause the ferritin level to go up, so it gives a false elevation of your iron stores as well. So very complicated, but here's a really good sets of information that we're learning. Thank you for sharing that, Aislinn.
All right, I think we can move on to the next slide. And I think one of my colleagues is going to be covering viral hepatitis. Is that correct?
Yeah. So just another a little bit of a different sort of like marker that can be measured in your blood is when the doctor might want to check if you have viral hepatitis. So a blood test would be useful to check if you have viral hepatitis because when you're exposed to hepatitis viruses, you're probably going to develop antibodies against those viruses. So a typical blood test that's checking for hepatitis antibodies would be one that might be checking for IgM, IgG, or IgA, which are basically just different types of antibodies that you might have in your blood. So when you have typical symptoms that might point at hepatitis, like fever and nausea, and often some sort of indicator that your liver might be compromised, like jaundice or elevated liver enzymes that might point at that liver damage. A doctor might order a test for viral hepatitis to check if you have antibodies to the hepatitis virus. And that's because the hepatitis virus tends to infect and cause like the most like the most damage to your liver. And so it's a good idea to watch out for these because checking these antibody levels can make sure that hepatitis can be managed and treated appropriately. So yeah, now we're gonna discuss hematology just a bit. I'm gonna pass it off to Matthew.
All right. Thank you, Jonathan. Yeah, so now we're just going to talk about hematology. And I guess, a blood test, we're gonna check what these things that are, supposed to be in the blood and make sure that their levels are okay. So the first thing we're going to talk about is hemoglobin. So this ties into what Aislinn said earlier about iron, because hemoglobin actually is the molecule on our red blood cells that helps it carry out its function of carrying oxygen throughout the rest of the body. So this is directly tied to your iron as well. So if you don't have enough iron, then you again might have these same symptoms to anemia, which is something that is low hemoglobin. So this can be due to many different things, including acute or chronic bleeding. So if you have an internal bleed, if they see a large drop in your hemoglobin at, for example, the emergency room, then that might be an indicator that you're bleeding internally somewhere. This can also be associated with chronic kidney disease or chronic inflammation. On the other hand, if you have high hemoglobin, this might be indicative of things like lung disease, smoking, genetics, or dehydration. And a really interesting thing is actually for all of you, I guess, long distance runners out there, having living at higher altitudes will actually increase your red blood cell count. So sometimes Olympic athletes and runners will go up to higher altitudes to train, so that way they build up that hemoglobin, and that enables them to carry more oxygen to their body cells. So that's kind of the way that they train without actually taking steroids or anything like that. So what you can do to this, as mentioned before, is you can try to increase your intake of iron. So taking those high iron-rich foods like broccoli, spinach, beans, those kind of things. Or you can also take iron supplements as well. But if you can, try to take the more dietary route because there are some really tasty foods that do also provide a lot of iron for you. We mentioned a little bit about white blood cells, and white blood cells are mainly, I guess, not that big of a concern or that of interest to Dr. Curnew specifically. They, with regard to the heart, but they are very present and indicative of infections. So the white blood cells consist of many different types, including neutrophils, basophils, eosinophils, and lymphocytes. And they work by destroying foreign organisms as well as producing those antibodies. So a lot of talk about those antibody production with the whole COVID vaccine going around. So when you have low white blood cell count, this could be something like leukopenia, which may be indicative of bone marrow disorders or autoimmune diseases as well. And if you have high white blood cell counts, that might be caused because of infection or inflammation or even leukemia. So these are just some of the basic hematological markers that we can see. Dr. Curnew, do you have anything to add for this section?
No, I think you covered it well. I'm certainly not an expert when it comes to that, but you can see that having your white cells in the right types and right places is good. Thanks. And sort of looking at hemoglobin platelets, and thanks for sharing that.
Yeah, and now we're just going to go on to the last, I guess, main constituent of blood, which is the platelets, as Dr. Curnew talked about. So next slide, please. Awesome. So these platelets are really important because they help your blood clot. So, you know, when you get a little cut, the reason why you don't bleed out from that little cut is because you have those platelets coming there to make, you know, nature's Band-Aid to kind of clot up that and stop you from bleeding out. So if you have low platelets, obviously this can be problematic. And this is known as thrombocytopenia. So this can be due to impaired platelet production, immune disorders, where your immune cells, white blood cells, actually attack your platelets themselves, or chemotherapy. And if you have high platelets, this can be a result of injury, inflammation, or cancer. So one of the important things that Dr. Curnew might send you in for, or if you have any specific issues regarding clotting and coagulation, is something called the International Normalized Ratio, or INR, which is actually also heavily related to something called the prothrombin time. And what that is it determines how long it takes your blood to clot. And so for an INR, you want it to be between a level of 2 and 3. And what happens here is that this ensures that you're clotting at the right rate. If you have a low INR, which means that your blood is clotting too quickly, what can happen here is this increases your risk for strokes, for pulmonary embolisms, and for thrombosis in your blood vessels. So these can cause obstructions and lead to a boatload of different diseases. And this is specifically important for people who have mechanical heart valves because they're susceptible to this thing called prosthetic valve thrombosis, which is why you might be taking warfarin for the rest of your life. And if your INR is too high, and this means that your platelets are, you know, they take too long to actually form that clot, you're at an increased risk for bleeding. So these can be like hemorrhagic strokes, these can be internal bleeding, stuff like that. So also not good. So you want to be in that sweet spot of 2 to 3. And the reason why we're talking about this mainly is because. Go ahead.
So normal INR is actually 1. So
Okay.
2 to 3 means is that if you're taking a blood thinner called warfarin, we thin the blood to get to that range from 2 to 3. And it's kind of interesting is that if you do not use warfarin or Coumadin, you're using things like apixaban, edoxaban, Xarelto, rivaroxaban, Pradex, you don't actually have to measure the INR value. In fact, it's measuring a different clotting factor. So that eliminates that need. But basically for warfarin or Coumadin, traditionally you want your INR between 2 and 3 to make sure your blood is just thin enough. So we talked about liver function tests when we started a little bit earlier. Liver produces clotting factors. And if your INR is above 1, that means your liver is not clotting properly. So we can measure liver function tests from those blood tests we measured before, but the actual liver function that we actually measure is one that's called albumin. It's a protein in your bloodstream, and we measure INR values to see if your liver is functioning or not. So important now is aspirin, for instance, doesn't affect any of these blooding parameters. It doesn't affect your platelet count. It doesn't affect your INRs, but it does make your platelets don't stick as well together. And now that we have interest in blood clotting problems or with the AstraZeneca vaccine, for instance, you can actually form an autoimmune process will attack your platelets. So platelet counts, you mentioned normal is above 130 to 300 range, is that if you took the AstraZeneca vaccine, you get these bad headaches, you have a blood clot, and your platelet count's depressed, usually around 30 to 50,000. That's a marker that you've developed a problem there with your antibodies to platelets. So lots of things to worry about, to think about. So we're not going to make hematologists out of all of you, but good information. Go ahead there, Michael.
Yeah, thanks, Dr. Curnew. Like Dr. Curnew said, the 2 to 3 is mainly for those patients who are on warfarin. So those people who have mechanical heart valves, but if otherwise it would be around 1. So thank you for that. Yeah, so that's about it. I have to talk about platelets and coagulation. So we can go to the next slide then.
Okay, thank you, Matthew. So at this point, that brings us to a wrap for our section on biomarkers, and we wanted to just briefly discuss a certain type of medications. Now, this next category of discussion, statins, certainly could be devoted to its own webinar, and we've already done that as well. You can find that on our YouTube page if you're of interest to that. But we just wanted to discuss medications for managing your cholesterol and a bit about understanding science and when to know when scientific information is credible information and when to differentiate when information may not actually be the best resource to look into. So let's move on to the next slide and let's discuss how statins work. So statin medications are meant to help lower those bad cholesterols, those LDLs in your body, and raise those HDLs, which are the good cholesterols in your body. And from what, of course, science has told us is that this is fantastic in reducing the risk of heart disease and significant cardiovascular events. Well, how does it work? Well, you can see on the left-hand side of the slide, we sort of provide a diagram for a very simple breakdown of how these medications work in the body. Jonathan, would you mind clicking the slide one time for me? And you'll see that essentially statin medications come in and they inhibit a certain enzyme in the body known as HMG-CoA reductase. And subsequently what this does is it stops the process of cholesterol making that takes place in the liver. Now, there are two medications which you're probably very familiar with. The names are Crestor and Lipitor, or rosuvastatin and atorvastatin, respectively. And these are the strongest or most effective statins available on the market. But of course, there are a number of different statin medications available. On the next slide, we're going to be discussing the benefits of statin. So from research, we've come to learn that for every 1 millimole reduction of your cholesterol, this is associated with a corresponding 22 to 23% reduction in major vascular events. Furthermore, there's a 20 to 25% reduction in having a heart attack or a stroke. As we mentioned previously, Dr. Curnew has his optimal ranges of 3, 1, 1, 1 for your total cholesterol score. And as you can see, those are numbers that are lower than what is typically considered the average, because we're not only trying to be average, we want to optimize your chances of living a long and healthy life. So overall research has showed us that a greater reduction in your LDL, which is those lousy cholesterols that we don't like, will lead to a greater protection from having a major cardiovascular event in the future. Now, according to Harvard Medical School, the benefits of statin are extensive. For example, they have anti-inflammatory properties, they improve vascular function, they help to stabilize the cholesterol-laden arterial plaques that build up in your blood vessels, they inhibit platelet buildup, they reduce the thickness of your blood, and all in all, as a side benefit, they also reduce the risk of having a stroke. So all in all, statin therapies offer many significant cardiovascular events, which far outweigh the potential risks which many people seem to sort of point to whenever they consider the drawbacks of statins. Dr. Curnew, is there anything you wanted to mention at this point?
Yeah, I think it's important to understand this. So if your average cholesterol is around, let's say 5, 5.5, let's say it's 5. So you start off with an LDL cholesterol of 3.5. Well, if your LDL cholesterol is from 3.5 to 2.5, you lower your risk by 23%, around 20%. And if your LDL goes from 2.5 down to 1.5, you get an additional 20% reduction. So you can see for every 1 millimole reduction of LDL cholesterol, your risk of heart disease and stroke falls by about 20% or so. And there's no threshold. Lousy cholesterol is lousy cholesterol. There's nothing good about LDL cholesterol. So for instance, if you went from an 4 down to 3, then to 2 or to 1, that's basically 3 times 20. That's a 60% reduction after having things like a heart attack and stroke. And so to me is that in very high-risk people who've had more than one heart attack, or if you had one heart attack, or if you have diabetes, I would want my LDL cholesterol to be less than 1. So if you want to stop at 2, terrific, but from going from LDL cholesterol 2 to 1, you actually lower your LDL cholesterol by additional 20% or so. And again, it's independent of the starting baseline cholesterol values. And that's why I have this 3-1-1-1 rule, is that I want my healthy cholesterol above 1, I want my triglycerides less than 1, and my LDL cholesterol less than 1 if I have my ideal dream team. Do I get that in everybody? Absolutely not. And can you get LDL cholesterol too low? No, lower is always better. And for some people, I'm glad to erase LDL cholesterol from the planet. It's like saying is, how many COVID cases do you want in your environment? None. LDL cholesterol is just bad cholesterol. You don't need it. All your cells can make its own cholesterol, except for mature red cells. So each cell can make its cholesterol it needs. So you don't need LDL cholesterol in your circulation.
Thank you, Dr.
Thanks,
Curnew.
Stuart.
Thank you. On that note, I wanted to just transition into discussing the dosages and the effects of these statin medications. So here you can see a diagram backed by science which shows many of the different statins and how a greater dosage helps lead to a greater reduction of those lousy cholesterols, ranging from about 20% all the way to 60%. And with this in mind, I wanted to ask you, Dr. Curnew, how do you sort of decide what's an appropriate dose for a patient whenever they're being put on a statin medication?
Well, it's like, how many superstars do you want on your sports team? I want as many as I possibly can. And rosuvastatin, Crestor, 40 milligrams a day can lower LDL cholesterol by 60%. Atorvastatin or Lipitor, 80 milligrams a day, lowers my risk of lowers LDL cholesterol by about 50 to 55%. Why do you want anything less? And people say, do I take a highest dose of medications? No. You get good effects from a low dose. For instance, there's drinks like simvastatin, pravastatin, lovastatin, fluvastatin. These are older drugs that I barely use at this point in time because they're just not as good. And so I tend to decide with you what the best dose is. So a 10% reduction of LDL cholesterol over a lifetime translates to a 50% reduction of risk, or a 50% reduction of LDL cholesterol over 5 years also lowers risk by 50%. So you have to decide with your doctors what you want to do, and most of us tend to underestimate or underutilize the power of a statin therapy. These are phenomenally good, effective, and safe drugs.
Thank you.
So it's an individual decision.
Thank you. So we'll move on to the next slide, Jonathan, and we're just going to do a brief refresher of this standard system, which we've mentioned multiple times now. But remembering the 3-1-1 system is important whenever you go to look at your lipid values on your next blood work appointment. And just as a refresher, what we're talking about for statins is lowering LDL cholesterols, which are those lousy cholesterols that we wish to get rid of in the body. We want to eradicate those, as Dr. Curnew said. You want to get rid of as many COVID cases in your area as humanly possible. There's also good cholesterol, so it's important to recognize that for your HDLs, this is a number that you'd actually prefer to have greater than 1. And again, the reason why is because these are actually working on your side to help get rid of these LDLs or help put them in a place where they need to be filtered and processed properly. So just keeping that separate in your mind, understanding the difference between these lousy cholesterols, which we want less than 1, and the HDLs, which we like to be greater than 1 if possible. And with that, we'll move on to the next slide. And we're going to be discussing very briefly European guidelines. So this is a guideline which was built and created over a number of years with many different patients involved. And what they did was they monitored patients with at various levels of cardiovascular risk. And essentially they assigned them a score called the Systematic Coronary Risk Estimate. And from there, they were able to determine whether individuals were at a moderate risk, a high risk, or a very, very high risk of having a cardiovascular event in the future. So, for instance, a very high risk was associated with having 2 vascular events within the past 2 years, or having a 10% risk of having a fatal cardiovascular event within the next 10 years. And as you can see, the greater at risk someone is, the more you want to lower that LDL, because it's really not doing an individual any favors. Now, while an individual at moderate risk may have a goal of being less than 2.6, as Dr. Curnew said, there's really no benefits to LDL backed by science. And so getting a number as low as humanly possible to the point of even eradicating it from your body is something that you want to continue to try and work towards. And of course, statin medications, while a choice, are one of the best ways to help you manage that and do that.
So I'll just give myself, for instance, I don't have heart disease, but my dad had his bypass at the age of 50. I have a high LP little a, so does my son. And we also have diabetes in the family. Now, I don't have diabetes. My brother has diabetes. My dad had diabetes. And what I'm doing is I'm doing everything I possibly can from diet and lifestyle changes. I'm trying to keep my body mass index under 25, and I'm always hungry, and I'm always trying to eat less and exercise more and pick the right foods. I get it. That because I have a genetic marker in me for heart disease and a positive family history, I'm more aggressive in my management compared to somebody who has longevity in their family. I hope to be working around the age of 100 years of age, and to me, part of my repertoire is I need to be on the highest dose of a statin. It'd be foolish not to. Now, in your case, we'll have to individualize, and that's what I like about the European guideline. It breaks up quite nicely, and the Canadian guideline says something similar, not quite as aggressive, and Canadians sort of compromise a little bit, but it's lower is always better, and the Canadian guidelines saying that. So lowest is best, and so the European guidelines puts that out quite nicely. And frankly, is that if you had your first heart attack at 40, you're going to have another one if you're not careful. And I would get my LDL cholesterol to less than 1. If I'm a type 2 diabetic on the age of 40 years of age, you unfortunately have lost 15 years of life. Let's get some of that back. So let's actually work on that. Thanks.
Thank you. So now we've looked at sort of what the guidelines say, what the recommendations are, but how is it backed by science? Well, on the next slide, we want to show you something known as a meta-analysis. And I like to think of a meta-analysis as a democracy. Essentially, what these researchers did was they asked every single member who's ever done a study at that time, measuring what they want to look at, which is cholesterol medications and whether it reduces the risk of having a cardiovascular event. And they consulted every single member, they pooled all these results together, and they came out with their own outcome. So taking into consideration what everyone has done in the research world in the past, what do these results say? So what the researchers did was essentially they were looking at cholesterol medications and whether they minimize the risk of having an adverse cardiovascular event. So they pooled participants from many, many studies, creating a pool of over 300,000 patients to evaluate the efficacy of statin and non-statin medications and lowering those ugly, lousy, bad cholesterols. And essentially the results that the researchers found was that, backed up by what we said on a previous slide, there was a 23% risk reduction in cardiovascular events for every 1 millimole reduction in cholesterol within 5 years of using consistent statin medications. So all in all, what does that mean? Well, if we click one more time, we'll sort of get a little message from Dr. Curnew, who's telling us that we shouldn't underestimate the importance of medications in managing and achieving our optimal lab results. Statin medications are one of the strongest drivers for helping to manage and get our cholesterol within optimal ranges, in addition to other medications as well. That on top of having a healthy diet, and of course living a healthy, active lifestyle. And while we're on the topic, let's talk about the hierarchy of evidence. So I just talked about a meta-analysis, and as you can see, it kind of falls at the top of the pyramid in terms of the best level of evidence available in the research world. And why is that? Well, for starters, it's secondary information, meaning they're not the first researchers to look into this topic. Instead, they pooled researchers' results from other studies and brought it all together to sort of get an opinion that everybody agrees on. So they looked at the results of every single study, and that's how they came up with this evidence. So whenever you are looking at research, for example, looking for things such as clinical practice, the term guidelines, or looking at systematic reviews or meta-analyses are often the best way to determine whether the evidence is appropriate for you to consider as valid and of high quality. Moving on to the next slide, one thing that you will maybe have come across is the idea that statin medications may cause muscle pain. And if you look on the internet and you look up statin medications or statin tolerance, you'll get over 3 million hits which tell you that statin medications can cause muscle pain. So what researchers have done in previous studies was they wanted to look at patients who stopped taking statin medications because of the pain that it was causing them. And so what they did in this study, known as the Samson trial, was that they recruited 60 patients who previously stopped taking statin medications because of statin-related pain that they found unbearable and that was not beneficial to them, didn't outweigh the benefits of the medications itself. So what researchers did was they grouped individuals into 3 interventions. There was the group that was receiving the statin medications. There's the group that received the placebo, which is medication that's meant to look like a real medication, but really there's nothing in it. And finally, they gave the individuals 4 empty bottles of, well, nothing, air. And if we move on to the next slide, you'll see what the results were for this study. So what they did was they asked patients to start a new bottle every single month. And of course, these patients didn't know the difference between whether they were taking their actual medications or whether the pill that they were taking was a placebo. If we click on the slide a few more times, you'll get a visual representation of what this study looked like. As you can see, there was 3 different types of bottles, but of course they weren't labeled. They had no idea what was in them. And essentially, after every month, patients were asked how they rated their pain on a score of 1 to 100 after every single month. So I bet you're curious what the results were. Well, we'll find that on the next slide. First, before we go into the results, it's important to understand what the nocebo effect is. The nocebo effect essentially is the phenomenon where the act of taking a pill makes someone feel worse rather than better. And what they found from this study was that the individuals that were not taking pills, they had a baseline score of about 8 out of 100 in terms of their pain level. Now, when they looked at the placebo group as well as the statin group, they found that their scores were 15.4 and 16.3 respectively. Now, when they ran the results, they found that there was no significant difference between these 2 results itself, and that the placebo group and the statin group essentially reported the same degree of symptom severity. And all in all, the researchers were able to conclude that 90% of symptom burden from statins was actually elicited by the placebo medications itself. So this study is really interesting because what you can sort of conclude is that the implications of this trial is that the pain that the patients were experiencing is of course real, but most of it is actually due to the nocebo effect, which seems to be elicited by the act of taking the pill, not necessarily the ingredients in the statin medication themselves. And so if we move on to the next slide, you'll sort of learn the takeaway from this study and why we wanted to show it to you. It's that statin medications are life-saving medications, and that it's important for you not to stop your medications without consulting your physician and you're reviewing your blood work with them. Your lab results tell a story, and your medications are working to try and get you in the optimal ranges that your body wants to be in. So if you have any concerns about medications, always discuss with your doctor before making any changes yourself. Dr. Curnew, did you want to add anything about that?
Yeah, so it's kind of interesting. These were people that had intolerable symptoms. These are people that could not take a statin, that got really sore within a couple weeks of therapy on average. And they were given either real pill or fake pill. They didn't know about that. And at the same pain. They're also given a jar of just an empty jar. And so when they knew they were taking nothing, they felt better. They didn't feel perfect because pain is pain. In fact, if you make it to 50 plus, I have pain every day of my life, so I'm aching pain. That means I'm still alive and still kicking. That's good. We get achy and things of that nature. We have some aches and pains, arthritis. I get that. But it was really remarkable. These are people that had really terrible limiting pain. And the pain's real. And the pain is just as common on a fake pill or a real pill. So, and this is not the first time this was done. This was done multiple times. And the reason that's so important is that when you stop these life-saving medications, you have more heart attacks, you have more strokes, and you die. So I think it's really important to look at your psyche and things of that nature. Are you just not a pill person? Some people, listen, I get it. I just want natural approaches. I don't want to take any pills. So thank you, Dr. Curnew. Please don't give me these pills. I'm gonna do the same thing, and that's okay too as well. But when you look at the power of these medications, if you get your LDL cholesterol down from 4 to 1, you decrease your risk of having a heart attack or stroke by 60% in 5 years. So you have to decide that's worth it to you or not, and really finding out for sure if it's the medication or the thought of taking medications. And we're involved in a project about this, and if you want, we can actually try to give you fake pill, real pill, deceive you, and find out if it's really the concept of the act of taking a pill or just the thought process. Now, this is not a replacement for lifestyle changes. I'm saddened to hear that most people don't want to do the work that's necessary to be on lifestyle changes. 8% of your cholesterol is made by your liver, 20% is what's in your diet, but you can influence that quite a bit. So to me, this is really a fascinating story, and I encourage everybody to look at a couple of videos. One is called the Statin Debate, and that's actually kind of something to think about, how we're influenced. And so thanks, Stuart.
No, thank you. Jonathan, if we can move on to the next slide, we'll learn that Dr. Curnew is a bit of a mind reader, and that we have slides for the statin debate. So as Dr. Curnew mentioned, we have a student who put together a great webinar, a great comprehensive discussion on looking at all of the research available on statin medications, just so that you can make an informed decision yourself. So if that's something that you're interested in learning more about, you're more than welcome to check the link underneath this video, and you'll be redirected to that video on our YouTube page. Transitioning into other videos that we've done on the topic, very briefly, we recently posted an animated video presenting a case study, if we can move on to the next slide, presenting a case study on an individual named Bob. And we just sort of looked at what his statin medications are doing in his body and how it's working for him. So if that's something you're interested, you're more of a visual learner, you're more than welcome to check out that video on our page as well. And one more plug-in for another video we've done in the past. If we move on to the next slide, this is sort of a bit of a I jumped the gun. That's the next slide after that. So improving your test results, it's important to understand that there's a bit of a trifecta. So as Dr. Curnew said, medications are not a replacement for lifestyle interventions. They're one part that can help you get going. But of course, having a healthy diet and living a healthy, active life is also crucial and imperative in helping you lower your risk of cardiovascular events to the fullest extent. And there was also a study done by Harvard, we'd love to refer to it as well, which suggests that you can't underestimate the importance of having quality relationships in improving the longevity, improving your longevity and minimizing the risk of having adverse cardiovascular events as well. So this is sort of the big trio: exercise, healthy diet, and of course, as we discussed, medications.
So we actually gave you some stuff on blood work. So we know that statin therapy can affect the liver, causes a liver function abnormality. ALT goes above 100 in between 0.1% to 2% of patients on statin therapy. That doesn't translate to actually any liver damage for most people. If you're worried about muscle soreness, muscle weakness, we measure muscle CK, and we know that just walking, running down the street causes CKs to go up to 500 or so very commonly. So that's why we measure the CK. So I don't usually get concerned to the CKs above 1,000 to 2,000, or you have true muscle weakness. We also worry about things like renal failure. So if you're not peeing, can't pass any urine, we'll measure the creatinine and the GFR to look at that effect. So you can see that there's always safety in monitoring. So that's why we tend to do that. So my pattern of practice somewhere between, if you're a diabetic, you should get that hemoglobin A1C every 3 months, for instance. If you have congestive heart failure, you might, on 5 different drugs, you might need to have electrolytes and renal function and kidney function done every couple of weeks, for instance. If you're feeling tired or weak along the way, maybe you have to look at your iron, your ferritin level. Is that a problem? You need to look at that. So these are just some examples at what we can look about this. And we just learned about Medjos and getting requisition forms. I encourage people to, once you get your requisition form, to have extra copies. A, you lose it. And number 2 is that if you need to have blood work, we can discuss together what needs to be done and what boxes to check off. And if you have a requisition form, we can do that together. So don't be afraid to empower yourself and also just monitor. Go ahead there, Stuart. Thanks, and the rest of the team.
Okay, thank you. Jonathan, if we can move on to the next slide. We just wanted to present one more video that we've done recently, and this is sort of a comprehensive look at all the common risk factors associated with heart health, not just cholesterol, which we've talked about, but also your blood pressure, your age, smoking, diabetes, stress, and weight. So if you have suboptimal blood work results and you want to learn maybe about some of the risk factors that may be predisposing me to these results, this is a great video for you to check out, and you can find it on our YouTube page just by looking at the title that you see on the screen. Thank you.
Important to remember, it's not the highest blood pressure, it's not the highest cholesterol. Risk factors multiply. They don't add, they multiply. So having a little bit of a weight problem, a little bit of a blood sugar problem, a little bit of a smoking problem, a little bit of cholesterol, a little blood pressure, unfortunately, those are the people that die of heart disease first. And I start off looking at my gut every morning and try how to get that a little bit smaller, so I can affect my blood sugar, my cholesterol, my blood pressure. They're all interactive. You can do it too.
Yeah, that's a great point. Thank you, Dr. Curnew, for mentioning that. And that sort of draws us into our next slide, where I just wanted to briefly discuss some of the other things that we do at our clinic to sort of help you. So we do have some different focus groups. We have our weight management club, which is run by some fantastic volunteers. We have exercise and meditation. We also have a monthly cooking club as well, where we cook and batch cooking with ingredients from across the country. And so these are all sort of different focus groups, which we now run over Zoom to keep it safe. But it's a great focus group, and it sort of just shows the power that having relationships and having a good support system around you can have. And we only see these groups continuing to grow. And so if you are committed to the process and you're really, really interested in these resources and would like to be a part of this community and helping to improve your health, then you're more than welcome to reach out to us. We have listed our email there on the screen for you to send us an email at drcurnew232@gmail.com.
And once the pandemic's over, we'll have them back in the clinic. We'll have them on Zoom. And also, if you want some individual advice from people, from, for instance, to smoking to how to cook healthier, terrific. I'm learning to be a better cook, and I really look at my my thought process, and I really thank the mindfulness group to help me understand that many of my behaviors are self-inflicted. So how to get better at that. So if I can do it, you can do it too.
Thank you, Dr. Curnew. Fantastic. So we're going to move on to one of the last sections, which we want to discuss very briefly today, and that's, okay, so I've done my lab results. Where do I find them? So now we want to discuss how you're accessing your lab results online through LifeLabs and through Dynacare. Next slide, please. So we've done 2 videos for both of these actually on our YouTube page, which you're more than welcome to check out. We're going to go in a lot more detail in those ones than we're going to today. But there we discuss how you access your lab results both from LifeLabs and Dynacare, how they differ, and what are some of the cool benefits that each of them offer. So if we move on to the next slide, we're going to first discuss how to access your results through LifeLabs. Next slide, please. So very briefly, a little bit about LifeLabs. It's a Canadian-owned organization and is actually the largest lab provider performing diagnostic tests and lab tests to help you monitor, detect, and prevent heart disease. And they've been running now, serving the needs of Canadians for over 50 years. Now, there are a number of different tests they do. Of course, blood work results. Many patients use LifeLabs as their #1 resources to get their blood work done. But there's also other tests as well. There's genetic tests, there's naturopathy tests, and there's also heart monitoring as well, which you can do, which we also do offer at the clinic as well. So moving on to the next slide, we'll see that this is an important note that I just wanted to briefly discuss about LifeLabs, in that it's important that your lab visit information lines up exactly with the information on file with the lab. If there's any discrepancies, they won't be able to do the blood work and you won't be able to actually access your results online. So it's important for you, as Dr. Curnew mentioned, to stay in communication with your healthcare provider so that you know what you need to get and to ensure that it actually lines up with what the lab expects you to get as well. And if there's any discrepancies, you're more than welcome to always call LifeLabs, where we've provided the landline at the bottom of the screen, for any concerns or questions that you have when doing your blood work. So next we're going to talk about how you book an appointment through LifeLabs. It's a very simple process. We won't go into too much detail. First and foremost, you just need to go on the website, lifelabs.com. There you'll see a big button where you have the option of actually booking your appointment. There, whether you've done this before or you're a first-time user, you're either going to log in with the username and password you've created, or you're going to register an account yourself. Finally, you're responsible for then booking your appointment at a time that's convenient for you. And there's also a Find My Location feature on the website where you can find the closest LifeLabs that are open during the pandemic available by appointment so that you can get your blood work done. And of course, all of those results are then sent to Dr. Curnew's office. And at that point, it's your responsibility to book a test with Dr. Curnew if you don't already have one, so that we can review the results with you to make sure that you get the appropriate and quality care that you need. Next slide, please. So just elaborating a little bit more on how to find a location. This is what the website looks like. And as you can see on the bottom right-hand screen, These are the many different options that they provide you. So whether you are getting a normal test, you can always click it off, but they also offer things such as ECGs, 24-hour Holter monitors, ambulatory blood pressure monitoring as well. And that's, of course, if your clinic doesn't provide that themselves. Here at Dr. Curnew's clinic, we do offer those. And also you can book by a time that's most convenient for you, and you'll find all the available appointment times available in your area. There you simply click a few buttons to register, and you're good to go. And if we move on to the next slide, we're just going to talk very briefly about some of the things you need for your appointment. Of course, the requisition form, can't forget that. That is a crucial piece of paper. Making sure that you are bringing a validated health card, which is up to date. Most routine tests are covered, of course, by your health insurance, OHIP. And then some form of validated piece of identification, whether it's your health card, driver's license, essentially anything that has your full name, date of birth, as well as your address that you're currently living at. Next slide, please. Now, in addition to your typical blood work results, there are a number of other tests that LifeLabs offers. You can see that they are offering COVID-19 testing these days, but there are a number of others as well. And you can discuss your eligibility with your family doctor, nurse practitioner, cardiologist, whoever's taking care of your health. And if you're eligible for a particular test, then that can be ordered for you, and you can subsequently then book your appointment and get your test done. Next slide, please. Briefly, we'll talk about Dynacare. One more time, we'll click it. And Dynacare, again, offers many of the similar features, offering clinical and medical testing, including blood work, and provides many of the same services as LifeLabs does. And of course, with it being online, offers many of the same conveniences as well. Next slide, please. So after you do make your account, you'll see that Dynacare actually has some cool features where you're actually able to look at all of your results online. So you can see, for example, this was mine. If I was to take a look at all of the tests I've done in the past, you can see, you can click on them and you'll be able to actually see an overview of your test results. And they give a bit of an in-depth analysis. Now, of course, this is not to actually replace a healthcare provider's professional opinion, but just gives you a sense of whether your results are within optimal or suboptimal ranges. Next slide, please. And similar to LifeLabs, Dynacare offers a number of additional tests as well. And again, it's important for you to discuss your eligibility with your healthcare provider if you feel like it's appropriate, or if your healthcare provider feels it's appropriate, for you to get a test that's outside of simple blood work done. Next slide. So here you'll see that there's also a few apps available which you can download from the App Store, whether it's on your Samsung phone or your Apple device. There is the Net Check-in for LifeLabs and Dynacare, which essentially allows you to say that you are currently in the waiting room and ready for your appointment while you are on the way to the clinic, so that it minimizes the wait times for you. And there's also Dynacare Plus, which essentially is a hub where you can take a look at all your previous lab results all in one place. And this is I guess an additional convenience that Dynacare offers.
Maybe it's not loud because battery is so down.
Sorry, say that again?
Yeah, it's all the way up.
Okay, perfect. Next slide, please. And I guess now we'll do a bit of an overview. So essentially for both Dynacare and LifeLabs, it's important for you to sign up for an account. Next step was for you to book your appointment online. The third step is for you to then access your results after you get your tests, and of course schedule your next follow-up appointment with your healthcare provider. And an optional fourth step for you would be to actually download some of the apps which I showed on the previous slide to help you sort of stay on top of your health while you're on the go. Awesome. Next slide, please. And at this point, Aislin's going to take it over with one slide discussing preparing for your visit.
So, as we all know, preparing for your visit is very, very important. You want to be ready to basically discuss everything with the doctor to get the most out of your appointment. So, next slide, please. One of the biggest ways that you can be prepared for your appointment and get the most out of it is to bring your medications list. So each year in the US, you get around 7,000 to 9,000 people dying from medication errors. And more than 40% of medication errors result from improper medication reconciliation, which basically means that errors arise during transitions between healthcare services. So that's things like coming home from the hospital or having appointments with specialists. And 20% of these medication errors will result in harm to patients. So these errors can be things like having the patient on a different dose of medication than they actually are taking, not knowing that a patient is taking a medication, or believing that a patient is taking a medication that they aren't. So medication reviews, much like we do in office and over the phone for your appointments, result in huge decreases in medication errors, which reduces harm to all of our patients and to everyone watching. So often these stats can feel really far away from our own lives, but we frequently receive out-of-date medications lists that have incorrect medications or dosages at the clinic. Much like Stuart said, there's kind of a big research paper that's gone around that says that only about 17% of medications lists are accurate, and we don't want that to be the case at the clinic. So it is best practice for you to bring in the medications that you are taking every time that you have an in-office visit. So ideally, you can bring in the actual pill bottles. If you don't have those handy, a list is second best. And we want you to go over your medications list with a member of our team every time that you have an appointment, whether that's in office or on the phone. Obviously, there is a little bit more difficulty with phone appointments. If you have difficulty pronouncing medications, you can spell them out or ask us to read what we have on our list and cross-check it. If I'm not mistaken, Stuart, correct me if I am wrong, but I think that there is an email that you can send in your medications list to as well, and we can cross-check it with what we have. So changes in your medications can be both affected by and have an effect on your blood work. So things like starting an SGLT2 inhibitor can explain a recent decrease seen in your eGFR, but it will also protect your eGFR long term. So if you have a decreased eGFR and you're not already on an SGLT2 inhibitor as a diabetic, then that can be a really, really good option to protect your kidneys. So having that updated medications list is absolutely vital to your treatment and your health. And without an accurate medications list, we can't provide the best treatment for your conditions because we don't know how you're already being treated.
Okay, thank you so much, Aislinn. And just like that, we've reached the end of our webinar today. So if we move on to the next slide, we'll provide a bit of a key summary or key breakdown of some of the important points we discussed before we sign off for the evening. So first and foremost, your blood work results can tell you a lot about your current health, not just in the context of a cardiologist's perspective, but from any healthcare provider's perspective, really. Cholesterol, HbA1c, eGFR for your kidneys, ALT for your liver, your electrolytes, sodium, potassium, ferritin. These are all markers that a cardiologist would be interested in learning more about, and these are markers that Dr. Curnew often requests whenever you get your blood work done. Now, in this webinar, we presented you with a number of optimal ranges for your blood work, and it's important to know where you stand in the context of these ranges, and learn to be a bit of your own detective. Be critical or be curious to know and learn more about your blood work. And we thank you for joining us today for the webinar to learn more about some of the research behind the things that we're discussing. Furthermore, the trifecta, exercise, a healthy diet, appropriate medications, these are all crucial in helping you achieve the best possible results. Of course, medications are not a replacement for healthy lifestyle interventions, and that's why exercise and a diet are also things that are crucial to maximize your health. Now, if you do ever have concerns about your blood work results, it's important for you to consult your doctor right away. When you book or complete a blood work exam, it's also strongly encouraged that you book a follow-up appointment with your doctor or your cardiologist, Dr. Curnew, to review your test results with our team together. Thank you so much.
Fantastic. What's in your blood? It's something we've been willing to do for a long time. You can see that one size does not fit all. Interpretation is into context. And we had a good question that was asked about how to interpret blood sugar individually. We have to do that together, and that's why it's really important to you be part of your healthcare team and learning a little bits about blood work. So this is actually quite a bit to absorb. Other pillars of health, of course, is things like meditation and sleep. So we just had a webinar a couple weeks ago on sleep, and I realized I have to change my sleeping pattern. So I've put some changes into place right now. And one of the things that gives me better sleep is exercise, and many of us haven't had the joy of exercising as much as we can, but also getting more sleep. So that's something to think about, and making yourself healthy. Be part of the healthcare team. So I want to thank everybody for participating. Lots of good information. This is one that you have to stop and start a number of times. I keep reminding myself that a hemoglobin A1C and a blood sugar are two different measurements. They don't measure the same thing. That your kidneys, if your kidneys don't cause you pain, and, that's when your GFR is around 15 or so. That's when things are going to go bad. Now you might feel sluggish and things of nature around 20, 30 or so, but most people who have a GFR of 45, where half their kidneys are still working, feel perfectly well. And obviously your kidneys aren't well. So blood tests can be important. And sometimes simply picking out that you're either iron deficient or you're anemic, that makes sense. And that we mostly can reassure people that their cholesterol pills aren't damaging their liver, so you measure the ALT. And the muscle enzyme are normal, so no serious damage to your muscles can be very, very helpful too as well. So thank you for sharing that. Are there any questions out there from anybody?
It looks like we do have one question. One of them was asked earlier in the webinar. How do you determine what your blood type is? Is there a special test for that?
Yeah, there's a special blood test for that, and it's not something that we do on a regular basis. Now, some people think about knowing their blood type will tell them a lot about their health. Not really. The only time you need to have your blood type really is to know if you need a blood transfusion. And as you mentioned, that most information is wrong in charts and things of that nature, so there's no lab in the world that's going to trust you that you know your blood type. So what will happen, it will be tested beforehand, or you'll get O negative blood if in dire emergencies. And so one of the gifts of life is blood. If you can give blood, give blood. It's a good thing to do. And knowing your blood tests is not really. I don't even know my blood type. I don't really care. It doesn't really. Only time I want to get a blood type is when I'm in a car crash or whatever, and then they'll do it in the hospital. They'll look after me in that circumstance. So. I do have my red donor, used to call Red Cross. We changed that right now, and I'm looking forward to getting back to giving blood again. It's been a while with the pandemic, so thank you for sharing that. Any other questions?
Does anyone have any questions?
No, thank you very much.
Okay, thank you. Jonathan, if we can move to the last slide, I just wanted to showcase a few things for anyone who's still interested in learning more with the things we do at the clinic. We'll go to the last slide, so we'll just pass through the references. There we go. So we do have an email if you ever do have any questions outstanding after this webinar. So if you ever need to learn more, or you want to get involved in some of the things we do for some of our focus groups, for example, or if you needed support with smoking, just to name a few things, you can always send us an email. That's listed on the screen. We also have a Facebook group where you're more than welcome to present your opinions, have discussions, things of that nature, and that's Dr. Greg Curnew's Life Group. We also have a new Instagram page where we're presenting important information, some helpful tips every few days, things for you to learn, things for you to know in a quick and easy way. So if you have Instagram and you want to give us a follow, you're more than welcome to do that. It's Dr. Curnew. And finally, we also have a Twitter page as well where we post updates whenever we post a new video or webinar, so you'll never miss a beat, I guess. So with that, I just want to thank everyone for joining today, everyone on YouTube, to everyone on WebEx. We had a great time tonight. I appreciate you being involved, appreciate your participation. And with that, Dr. Curnew, do you have any last words before we call it an evening?
Thank you. So I know what's in my blood. Do you know what's in yours?
Sounds good. Have a great night, everyone.
Good
Good
night,
night,
guys.
everybody.
Thank you.